This part is just to talk about what did you learn? What are the generic features? Are there any concepts that could be looked at either in comparison or together, some general concepts? And again, you'll have a wonderful amount of information to look at with your memory key, but just from this session, are there any generic issues or things that stick in your mind? It can always be better. Well, I think the corollary to that is stay open to change based on new information. Yes, I'm sorry.
To be open to different culture?
To be open to different culture, which is, I think, one of the things that came across here was that whenever the first interview was done, there was the sense, as I'm right, I got to get you to conform to my views, as opposed to how much do I change my views to meet the schema of the other person. There's a psychologist named Carl Rogers who's done very interesting work on client-centered therapy, where so much of the work of the therapist is to understand the patient's world and sit in their shoes in order to effect better treatment.
You change every 10 minutes. You change this story, change every 10 minutes. You see another story, and you need to adapt yourself.
And you have to be flexible.
Very flexible.
Another thing that Carl Rogers talked about is what's called positive regard. You accept the person in a positive way rather than judging them in any negative way before you start, which it gets into cultural biases.
Yeah. I'd raise a point of further thought. Was this? Did we really see? I mean, clearly the improvement was dramatic, right? But I'm not sure whether I saw a change of views, but rather a change of performance. Because inside the head, the sort of machinations, the differential diagnosis, what are the possible, tests we need to do, was kind of the same in both, version 1 and version 2. But the sort of, the presentation of it and the kind of negotiation around it was very different. So it's not like having, I don't think that the goal here is to, have the doctors practice poorer medicine. Right.
Well, is it poor or different?
Or is it even different? Yeah. I'll leave it as an open question.
I think this is a very interesting point of to what degree are we trying to understand the world while holding our 40 years of medical training in a Western traditional model? Are we expected to change it, or are we expect to incorporate what's different? So I think you're right. There's going to be a somewhat of a tenacity. It's not our job to necessarily become chameleons, but to incorporate. I think that's your point. Yeah.
Well, what time can we ask the patients the history of the abuse or the family background? What is the occasion? Time.
What is the occasion? That's a whole other lecture we could give. I think there were some elements of that. I think from my perspective, it's the context of the visit and the level of communication, gauging receptivity. I know that if a patient has a highly refractory set of symptoms for many years and a lot of comorbidities, I'm going to have a lower threshold to start to explore that. But I'm going to be doing it in a context of inquiry that's very gentle and supportive, rather than saying, have you been abused? I don't usually ask that, but I might say, has anything happened in your life that might have affected your illness or how you're coping with it? And I might go a step further and say sometimes people have had difficult experiences that can affect how they view illness. Give them the opportunity. If they fold their arms and say, I don't know what you mean, I'm not going to pursue it. But I might register that possibly that's a case, and it might happen on the next visit or the visit after that.
That's in American culture. In American
culture. Go on.
That's in American culture. Because in the transcultural setting, I don't know at the moment of asking this kind of question.
Well, I say I'm not directly asking the question.
Yeah, no, I'm not sure if I am going to ask this kind of question at any moment, because sometimes in some cultures that can be a taboo or something very, very, very complicated that I don't know how to deal with.
And I do think that in Western...
I'm going to open the door and don't know what's coming from...
In Western culture, it's very common for people to volunteer it given the proper environment. If they don't volunteer it, they might not even be fully aware of it. In other cultures, they may be aware of it but not volunteer it in that setting. I think that's your point. Well taken.
I wanted to comment on that. First, I don't think it's right to ask about that, especially not in the first visit. You need many visits and a lot of trust and confidence with the patients before you ask that. And usually what I've seen is that patients will tell you. There will come the moment when the patients will tell you without asking.
Okay. Any last words? Nobody. I want to thank Ben for steering this. Cecile, who's been in the background helping coordinate the group, and our actors who we've already introduced. It's really been a great experience. Thanks.